Hello and welcome, fellow student doctors, to our module on Hodgkin's lymphoma. The name Hodgkin's lymphoma tells you a lot about the disease. Lymph in lymphoma indicates that malignant lymphocytes are involved, and the oma ending tells you that these malignant lymphocytes form a mass, usually in a lymph node. This distinguishes lymphomas from leukemias because with lymphomas, the malignant cells are predominantly in the mass form, hence the oma ending. Whereas leukemia has the emia ending to indicate that the cancer cells are predominantly in the blood because that is what emia means. The Hodgkin's portion of Hodgkin's lymphoma also tells us that a key cell is present, the Reed-Sternberg cell, which has two nuclei that are mirror images of one another, just like the eyes of this owl. Coincidentally, the owl's name is Reed-Sternberg. Seriously. Whenever I see an owl, I quickly visualize the Reed-Sternberg cell that defines Hodgkin's lymphoma. Friends, Hodgkin's lymphoma is a very logical disease to learn because it's all based on these Reed-Sternberg cells releasing cytokines. It's a cytokine-driven cancer where up to 99% of the cancerous mass is of non-cancerous cells. You heard that right. The Reed-Sternberg cell, the defining cell, the cancerous cell of Hodgkin's lymphoma, makes up only 1% of the mass. Friends, we are in for an interesting discussion. Let's go ahead and get started. To prepare you for test day, you will be able to 1. List causes of painful and painless lymphadenopathy. 2. Explain the pathophysiology and presentation of Hodgkin's lymphoma. 3. Distinguish Hodgkin's lymphoma from non-Hodgkin's lymphoma. And 4. Identify the key side effects of the ABVD treatment regimen of Hodgkin's lymphoma. Understanding Hodgkin's lymphoma starts with understanding the workup of an enlarged lymph node. The first question to ask is if it is painful. If the enlarged lymph node is painful and movable, this likely represents an acutely infectious process, leading to reactive lymphadenopathy. Imagine someone with strep throat. The lymph nodes of the cervical region and even the supraclavicular region may be enlarged as it drains away that infection from the throat. That would lead to painful reactive lymphadenopathy. Conversely, if the enlarged lymph node is painless, firm, and fixed, that is, not movable, then you should begin to worry. First, you take a biopsy of that painless enlarged lymph node and send it for pathological examination, which may show 3 key findings. The first is metastatic cancer. Say breast cells are found in a painless enlarged axillary node. This represents metastasis of a primary breast cancer. So, metastatic cancers to lymph nodes can present with a painless enlarged lymph node. Secondly, chronic inflammation may lead to a painless enlarged lymph nodes. Conditions leading to chronic inflammation may lead to fibrosis, which would enlarge the lymph node. This may be seen in chronic inflammatory conditions with granuloma formation, for example, like from tuberculosis. Third, you may find malignant lymphocytes in that enlarged, painless lymph node, which would tell you that the patient has lymphoma. The next question to ask is whether or not Reed-Sternberg cells are the malignant lymphocytes found in the biopsy. If Reed-Sternberg cells are absent, then this patient has non-Hodgkin's lymphoma. Conversely, if Reed-Sternbergs are present, this patient has Hodgkin's lymphoma. This is a very high-yield discussion for examination purposes. Now, let's discuss those Reed-Sternberg cells in more detail as they cause all the features of Hodgkin's lymphoma. Hodgkin's lymphoma most commonly arises from a B cell within a lymph node that transforms into a malignant B cell called a Reed-Sternberg cell. What causes this B cell to become malignant? Well, Epstein-Barr virus is infamous for infecting B cells. Viruses, as you may know, can enter the nucleus of cells and as such can reprogram B cells to become malignant Reed-Sternberg cells. Moreover, immunosuppression can cause this as well, because patients on organ transplant immunosuppressives or HIV patients lacking T cells have downregulated immune systems, and the immune system is critical for clearing cancer cells from the body on a daily basis. The same story is true for patients with autoimmune conditions. The immune system is not functioning properly, predisposing them to Hodgkin's lymphoma. With that background, we need to talk about the Reed-Sternberg cells, which are unique because they are B cells that are positive for CD15 and CD30, but they are negative for other B cell markers like CD19, CD20, and CD21. When these cells go malignant, they go malignant all the way with these unique CD markers of CD15 and CD30, while lacking traditional B markers like CD19, 20, and 21. Moreover, looking at the Reed-Sternberg cell, you can see that it has a bilobe nucleus that resemble the eyes of an owl. As these bilobe nuclei, like the eyes of the owl, are mirror images of one another. So, when you think of two owl eyes, I want you to think of two owl eyes times 15, which equals 30. And this helps you recall the two lobes of the nucleus and the CD15 and CD30 positivity that characterize the Reed-Sternberg cell. Interestingly, these cells compose only 1 to 5% of the total mass of the lymphoma. Yes, as little as 1% of the Hodgkin's lymphoma mass can be of Reed-Sternberg cells. So how do these cells form a mass if they are such a minority? Well, look back at the cell. You can see that the nuclei have very large purple dots in them, kind of like pupils of this owl's eyes, huh? Each purple dot represents a nucleolus. Each nucleolus is so enlarged because they are pumping out rRNA, or ribosomal RNA, to create ribosomes needed for massive protein production from the Reed-Sternberg cell. This protein production leads to the release of massive amounts of cytokines, which are small signaling proteins. This drives the disease. These cytokines produced from the Reed-Sternberg cell recruit 95 to 99% of the tumor mass in the form of eosinophils, fibroblasts, macrophages, T cells, B cells, and plasma cells to the site of the Reed-Sternberg cell located in the lymph node. Incredible. Based on the specific type of cytokines released from the Reed-Sternberg cell, this leads to 4 main types of classical forms of Hodgkin's lymphoma based on histology. So, representing 70% of Hodgkin's lymphoma cases is the nodular sclerosis pattern. Let me ask you, what cell type is likely playing a major role in the nodular sclerosis pattern of Hodgkin's lymphoma? Well, that would be the fibroblast, which lays down fibrous tissue, leading to the fibrotic-looking lymph node here. Under the microscope, you would see nodules of immune cells in purple with bands of fibrotic tissue between them. Interestingly, the Reed-Sternberg cells in this variant are said to be in lacunae, or lakes. Google this image to see what I mean. The next form of Hodgkin's lymphoma, making up 25% of cases, is called the mixed cellularity pattern, where there is a mixture of immune cells found. The yellow arrow indicates the ever-present Reed-Sternberg cell. In this form, eosinophils are especially noteworthy. Test makers may simply ask what cytokine released from the Reed-Sternberg cell recruited the eosinophils. IL-5, very high yield. If you spell 5, it ends in E, with that E standing for eosinophils. Make sure you know that IL-5 recruits eosinophils. Next, there are 2 other forms of Hodgkin's lymphoma: lymphocyte-rich and lymphocyte-depleted, which both make up a minority of cases. Let me ask you, which form, the lymphocyte-rich or depleted form, do you think has a better prognosis? The lymphocyte-rich form has a better prognosis. Use logic. Normal lymphocytes, like T cells, kill cancer cells, right? In contrast, The lymphocyte deplete form arises in patients with immunosuppression like HIV, where T cells are lacking, so they have less ability to fight the cancer. And so the lymphocyte rich form has more lymphocytes capable of fighting the cancer and therefore has a better prognosis. On the last slide, we discussed what are called the classical forms of Hodgkin's lymphoma, which include the types listed here on the right. The classical forms have the classic Reed-Sternberg cell, which we have been discussing present. If there's a classical form, you just know there is a non-classical form of Hodgkin's lymphoma, which is called the nodular lymphocyte predominant form. This non-classical form looks like this and is characterized by the cell indicated by the arrow, which is called a popcorn cell. Look at it, and now look at this popcorn. See the resemblance? Well, this popcorn cell is a variant of the Reed-Sternberg cell and is CD20 positive and usually negative, yes, negative for CD15 and CD30. Hence, why this is called the non-classical type, because the classical types of Hodgkin's lymphoma all have the CD15, CD30 positive Reed-Sternberg cells. Lastly, looking at this histological image, it makes sense that this is called nodular lymphocyte predominant because of the diffuse background of lymphocytes recruited in by the variant Reed-Sternberg cell, the popcorn cell, which are present in this histological image. Revisiting our flow diagram, let's now discuss the clinical presentation of Hodgkin's lymphoma. The key point is to realize that Reed-Sternberg cells make up only 1 to 5% of the malignant mass, meaning that the cytokines those Reed-Sternberg cells produce drive the disease in its entirety. Cytokines recruit non-neoplastic, yes, non-neoplastic or normal B cells, plasma cells, T cells, fibroblasts, macrophages, and eosinophils to the lymph node. The types of cells recruited, as you may know, depends on the types of cytokines released from those Reed-Sternberg cells. All of this leads to painless lymph node enlargement. You may think with all those cytokines, the node would be painful. But remember, the Reed-Sternberg cells are a minority of the cells in the tumor that are secreting cytokines, and those cytokines that they are releasing are recruiting normal or non-neoplastic cells. So the enlarged lymph node is painless. Using the guiding feature that cytokines drive the disease, cytokines coordinate contiguous lymph node spread of the malignancy. What I mean by this is that Hodgkin's lymphoma is notorious for spreading in a continuous, contiguous manner, like down the cervical lymph node chain. This is good because if it's caught early with minimal spread, the prognosis of this cancer is actually very good. Again, I like to think that cytokines drive the process, and once the Reed-Sternberg cells call in enough cells to pack one lymph node, it moves on to the next lymph node in the chain and begins recruiting more normal, non-neoplastic cells, all driven by cytokines. So, cytokines coordinate contiguous spread of Hodgkin's lymphoma. Notably, lymph nodes may include the cervical, supraclavicular, axillary, or mediastinal lymph nodes. So, Hodgkin's lymphoma can present as a mass in the chest. Cytokines also drive the symptoms of the disease, such as fevers, night sweats, and weight loss. These are called B symptoms. I always thought they were called B symptoms because Hodgkin's lymphoma is caused usually by a B cell becoming a malignant Reed-Sternberg cell. But it turns out that the term B symptoms comes from the Ann Arbor staging of lymphomas, where A indicates no symptoms and B indicates symptoms, hence B symptoms. Cytokines also cause unique symptoms such as pruritus or itchiness. With all those cytokines released, they can lead to itching. That makes sense, right? Moreover, another unique symptom of Hodgkin's lymphoma is alcohol-induced pain of the enlarged lymph node. Don't memorize this for boards, but think if a patient has a mediastinal lymph node with Hodgkin's lymphoma. This may look like a heart attack after drinking wine. Amazing, isn't it? For the boards, stick to a painful supraclavicular or cervical lymph node after drinking alcohol. Recall, though, that the lymph node is painless but can become painful only after drinking alcohol in Hodgkin's lymphoma. Fascinating, huh? Lastly, I should mention that Hodgkin's lymphoma has a bimodal age distribution with a peak around 15 to 30 years of age and another peak around 50 years of age. While the treatment regimens for Hodgkin's lymphoma are beyond the scope of Step 1, test makers love to present the classic regimen used to treat Hodgkin's lymphoma and ask you about side effects of those agents. Friends, it's time to learn your ABVDs from Reed Sternberg the Owl here on the First Aid Express channel. Woohoo! Hodgkin's lymphoma is usually treated with radiation and chemotherapy, with ABVD representing a commonly used regimen. A stands for adriamycin, another name for doxorubicin, B for bleomycin, V for vinblastine, and D for dacarbazine. Using ChemoMan, let's go over the key side effects of these drugs because test makers love the vignette where they diagnose Hodgkin's lymphoma for you and then they ask you about a side effect caused by one of these agents. Adriamycin, doxorubicin, is a cytotoxic antibiotic that is notorious for causing cardiotoxicity. Hence the D for the heart of ChemoMan, which can be prevented by co-administering what agent? Dexrazoxane, high yield. Bleomycin is also a cytotoxic antibiotic that causes pulmonary fibrosis, hence the B's for the lungs of ChemoMan. Vinblastine is a microtubule inhibitor. Microtubules are essential for transmitting vesicles across the axons of neurons, and as such, this drug can lead to neurotoxicity in the form of peripheral neuropathy, as indicated in the stocking glove V pattern of ChemoMan. Lastly, dacarbazine is not shown on ChemoMan and is a less high-yield drug to know. Just know that it is an alkylating agent. Overall, Reed Sternberg the Owl thanks you for learning your ABVDs here on the First Aid Express channel. Now that we have talked about Hodgkin's lymphoma, I want to take a moment and broadly compare it to non-Hodgkin's lymphoma. In terms of malignant lymphocytes, both are characterized by malignant lymphocytes forming a mass, hence the name lymphoma, with oma meaning mass, being common to each. Conversely, Hodgkin's lymphoma is characterized by a specific type of malignant lymphocyte, the Reed Sternberg cells, with Reed Sternberg being the defining cell of Hodgkin's lymphoma. Therefore, it is absent in non-Hodgkin's lymphoma, which are more commonly characterized by specific chromosomal translocations. B symptoms are more commonly present in Hodgkin's lymphoma due to the massive release of cytokines from those Reed Sternberg cells, but can be seen in non-Hodgkin's lymphomas as well. Hodgkin's lymphoma spreads in a contiguous manner from lymph node to lymph node to lymph node, while non-Hodgkin's lymphomas have a non-contiguous spread to various lymph nodes, not in a specific lymph node chain or pattern. Considering epidemiology, Hodgkin's lymphoma has a bimodal age distribution from age 15 to 30, which overlaps nicely with Reed Sternberg cells being CD15 and CD30 positive, and those over the age of 50. Conversely, non-Hodgkin's lymphomas present in children and adults. A high-yield association for both Hodgkin's lymphoma and non-Hodgkin's lymphoma is the association with Epstein-Barr virus. This makes sense because EBV infects B cells and invades their nuclei, which can reprogram them into either form of lymphoma. Lastly, rarely does Hodgkin's lymphoma have extranodal involvement, whereas this is a common feature in non-Hodgkin's lymphoma. Extranodal refers to lymphomas developing in sites other than lymph nodes, like lymph tissues in the abdomen, think Peyer's patches in the ileum, or mucosal-associated lymphoid tumors, MALT tumors, in the stomach from Helicobacter pylori. Alright folks, it's time for our flash quiz. The question reads, 30-year-old male presents to clinic for evaluation of a painless supraclavicular lymph node. The patient reports night sweat, fevers, and that his clothes are fitting looser over the past few months. The lymph node is biopsied and a diagnosis of Hodgkin's lymphoma is made. What features of the cells led to this diagnosis? A. B cell, CD15 positive, CD30 positive, bilobe nucleus. B. B cell, CD20 positive, CD30 positive, bilobe nucleus. C. T cell, CD15 positive, CD30 positive, bilobe nucleus. Or D. T cell, CD20 positive, CD30 positive, bilobe nucleus. The correct answer is A. Hodgkin's lymphoma usually arises from a B cell that undergoes a malignant transformation into a Reed-Sternberg cell that is positive for CD15 and CD30. Remember, 2 times 15 equals 30. The 2 represents the bilobe nucleus of the Reed-Sternberg cell, and 15 and 30 represent these key cell markers. Notably, Reed-Sternberg cells are negative or do not have traditional B cell markers like CD19, 20, and 21. It's a malignant B cell after all, so it doesn't have these normal B cell markers. Make sure you could recognize this cell on test day and know the CD15 and CD30 positivity that characterize it. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. The differential for a painless enlarged lymph node includes metastatic cancer, chronic inflammation, or lymphoma, like Hodgkin's lymphoma. Hodgkin's lymphoma can be caused by Epstein-Barr virus, immunosuppression, and autoimmune diseases that lead to the malignant transformation of a lymph node B cell into a malignant B cell called a Reed-Sternberg cell. The Reed-Sternberg cell releases cytokines to drive the entire disease process by calling in non-neoplastic, normal immune cells that compose up to 99% of the mass. These cytokines also lead to the B symptoms of night sweats, fever, and weight loss. You must be able to recognize the Reed-Sternberg cell on test day, as well as its characteristic features. Use 2 times 15 equals 30 to recall the 2 lobes of the nucleus that are mirror images of one another and resemble the eyes of an owl, so-called owl-eyed nuclei. The 15 and 30 represent its classic markers of CD15 and CD30 positivity. Notably, Reed-Sternberg cells lack normal B cell markers like CD19, 20, and 21. Lastly, know the side effects of the drugs used in the ABVD regimen using ChemoMan. A stands for adriamycin, also called doxorubicin, and causes heart toxicity, hence the D on ChemoMan. Note, dexrazoxane can prevent the cardiotoxicity. B is for bleomycin, which causes pulmonary fibrosis, hence the B lungs on ChemoMan. V is for vinblastine, which causes peripheral neuropathy, hence the V arms and legs in a stocking glove pattern on ChemoMan. And D stands for dacarbazine, which is a less high-yield drug, but do know that it is an alkylating agent. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there is a great, big, beautiful tomorrow.